Thank you again for joining us for the second session in the sector webinar series and the second installment in the methods training. Before we get started, I just want to reiterate that you'll be chatting your questions in, and as Alicia said, we will be in full screen mode, so feel free to keep those questions to the end when you get back to the chat box and chat them in. I'll keep a parking lot, and we'll go through as many as time allows in the order that they came through. And again, make sure when you're chatting to send a host, presenter, and panelist. That way we can capture as many of the questions as possible. So without further ado, I'll turn it over to our presenter today, Dr. John Samet from the University of Southern California.
Okay, good morning or good afternoon, everybody. I guess I should say greetings from La La Land. Here we are in California. I'm delighted to be talking to people all over. I took this title, Causal Inference in Practice, to give you a description of sort of the state of the art, an art which has not necessarily changed so much over the half century since the first Surgeon General's report on smoking and health. I thought I would start by telling you about my weekend, which was spent looking for a new car because I have one of the painted VW diesels. This is some language that came out after the exposure of this problem in reporting of emissions. And you might notice I've underlined here in red talking about some estimates on the additional VW emissions that allow VWs to spew enough pollution to cause, note the word cause, somewhere between 16 and 94 deaths over 7 years and so on. So I thought it was an interesting example of a real-world problem, additional emissions, and what are the consequences. And of course, in the U.S., about 460,000 vehicles. This is actually not mine, but it's one that looks just like it. So this issue of additional risk and its consequences were part of a regulatory process here. Now, I want to start off by giving you just a very general model of decision-making, science-based decision-making in general. And the core disciplines feeding in are epidemiology, studying people, of course, in the real-world context, and toxicology, which is looking at consequences in animal models and various cell systems, which have become increasingly sophisticated, something I'll come back to at the end. And the first question there is there a hazard? Is there a risk? And this determination is embedded in regulatory language across the United States and, in fact, globally. So the first order question, we come to this question of, does Agent X pose a risk for one or more outcomes? And that pose a risk becomes this question of causality, and we'll come back to that. And if the answer is no, we may continue to watch and make sure our initial determination is correct. We perhaps may decide that there's indication of safety, sufficient bounding of possible risk to say, yes, it looks like there is no risk. Or perhaps the answer is yes, there is a hazard. And then in our typical paradigm of evidence-based decision-making, we would go on to say, how much risk is there? And this comes into questions of what epidemiology can supply and what toxicology can supply. Again, and a next step may be a quantitative risk assessment, looking in some way at how much risk there is. And that leads on then to the actual decision-making process, perhaps regulation, policy decisions, and so on. And if you're not familiar with some of the background work on frameworks that has gone on, I'll call your attention to two important reports from what is now known as the National Academy of Sciences, Engineering, and Medicine, the former NAS. The book in red, Risk Assessment in the Federal Government, dates to 1983. Guess what? It's called the Red Book. And it sets out a paradigm for risk assessment, for thinking about risks, and the burden of morbidity and mortality imposed on the population in a systematic way. The Silver Book, Science and Decisions, now about 6, 7 years old, provides a sort of an updated framework for making sure that important questions are answered correctly through the risk assessment process and the science generated in support of decision making. So these two read together would be a helpful background. Embedded within the Tobacco Control Act, of course, is the public health standard, and to look at that standard involves an assessment of risks and trying to understand what risk, what disease burden may be imposed on the population, what benefits there may be of particular products. So these are very useful documents as background. So in the Red Book, there's a discussion of risk assessment as having 4 components. Hazard identification, that's that question we already answered. I simplified the answer down to yes, no, but as we'll discuss later, there may be gradations of that yes, no, depending on the strength of evidence. Dose response, how does risk vary with exposure? Exposure assessment, what is the extent of exposure? And this is important when we put everything together in a step of risk characterization. So if we know the distribution of population exposures, we have some idea of the potential of susceptibility. We know how risk varies with dose or exposure or concentration. Then we can then characterize the disease burden. And in fact, SAMIC, the Smoking Attributable Mortality, Morbidity, and Economic Cost program of the CDC uses this kind of approach. What are the risks of smoking to smokers? What is the distribution of smoking to the population? Come up with estimates such as there are 488,000 premature deaths a year attributable to smoking. So this concept underlies this. Now, this idea of burden estimation goes back a long way. This is a picture of the Hopkins Epi Department about 1935 or 1936. The circle is on a faculty member then, Morton Levin. Those of you who know the early history of tobacco and lung cancer well will know that he was the author of one of the 5 case control studies on smoking and lung cancer published in 1950. His was in JAMA, along the same issue as that of Winder and Hoffman. A few years later, he wrote a paper on essentially disease burden. He said, I think smoking causes lung cancer. And if the disease is caused by something, then the next question we want to answer is, how much disease does it cause? And out of his thinking about this, and out of his paper came something we call the population attributable risk. It's the basic principles by which we calculate disease burden. So there's the formula, PAR, population attributable risk. It depends on the relative risk of whatever the factor is, smoking, say, and P, the prevalence of exposures. It's a very simple formula. And you can see that as either P rises or RR rises, then the burden of disease goes up. Embedded in this is the idea of causation, and in fact that RR, relative risk, is for a causal factor. And then the attendant promise that removing the exposure or dropping the relative risk, that would be harm reduction, leads to a diminution of disease burden. So very important ideas here that relate back to our quantitative risk assessment framework, where note we have hazard identification. Is there a causal risk? Dose response, how does risk change or vary with exposure? how many people are exposed, and then putting that together in this risk characterization step, very much akin to calculation of PAR, but in the risk characterization step, we typically would go much further and try and understand uncertainties and give a range of estimates based on those uncertainties. So what I'm going to do today is talk about the idea of causation, talk about sort of now pretty well ingrained approaches for establishing causation, which still rely very much on expert judgment. And I'm going to give you a few examples of frameworks. So we've got a lot to cover in the time here. So here's a quote from the 2014 Surgeon General's report. And this, actually, I'm sorry, this is from the 2004 report. And in that report, we sort of look back at the 64 report and the brief chapter there on causation and did some updating. So if you want to sort of look at what's been in the Surgeon General's report, look at 64, 2004, and then 2014. But this is important language from 2004. A causal conclusion conveys the inference that changing a given factor will actually reduce a population's burden of disease, either by reducing the overall number of cases or by making disease occur later than it would have. So there's an important concept embedded here, which is confidence that changing a factor will actually change disease burden. Okay? And of course, our goal is to reduce disease burden. So I think in practice, when we get to the point of saying causation, we are saying with confidence that, say, reducing smoking will reduce the burden of smoking-associated disease. Now, what about causation? I will only say as a casual reader of the literature here, of course, the philosophers have been debating what causation is for a long time. Some of this debate has slipped into the epidemiological and public health literature in general over time, but I will only say the discussion is ongoing. Hume's writings have had an important impact in public health and epidemiology. Some of the principles adopted into the so-called guidelines for causation. Most importantly is temporality. I mean, just to state the obvious, the cause must come prior to the effect, and usually we are reasonably certain about temporality, but sometimes the circumstances may be more complicated. This comes up, for example, with some of our new molecular studies in terms of sorting out the temporal patterns of certain molecular changes. And the second, an embedded idea that is important is the idea of the counterfactual. So when we do our studies, epidemiological studies, of course we're not beginning with a population where people are randomized to smoke or not smoke. We are comparing what happens to smokers compared to what happens to those who have not smoked, making the assumption that the differences we see are due to smoking, all other things being equal. And that is the idea of the counterfactual. We cannot say observe John Samet as both a smoker and a never smoker, but what we're going to do is substitute a John Samet never smoker for him had he been a smoker and try and equalize all things, which is what we do in our analysis. And so underlying this is the idea of the counterfactual, that we are making observations and making a comparison to this hypothetical condition. I use sports as sort of the best example of the use of the counterfactual. I mean, the sportscasters spend a lot of time talking about what might have been had not the truth intervened. And so here's a favorite example of this going back to when I was at Johns Hopkins reading the sports section. Here is a great example of the counterfactual. It's about a game that the University of Maryland played. They, as you can see, just squeaked by Delaware. But in this counterfactual game, if they made the 3 field goals they missed and get a few other breaks, they would have been sailing into the fourth quarter with a safe lead. So if you don't get the idea of the counterfactual from this, I just can't find a better example. So we make a comparison to what would have been absent the exposure, and this kind of counterfactual thinking underlies a lot of our current causal inference practice. So when we go back, I want to go back to the 1964 report as a starting point. To my knowledge, this is the first time that our government stepped forward and said, something causes something. Smoking causes lung cancer. It was actually in men was the conclusion. And something should be done about this. I mean, that's sort of the very important sort of sequence in the report. A causal determination and a call to action about this, a statement that smoking was a problem of sufficient magnitude that action needed to be taken was embedded in the report. So the causal conclusion became the basis for saying that we needed to take action. So the 64 report, and then as I mentioned, the 2004 report providing that update. Now, one of the sort of challenging questions sometimes with a mean streak, ask my students to define what a cause is, and they sort of blanch and say something, well, a cause is something that has an effect, which is kind of circular, but this is the definition from the 64 Surgeon General's report, where they talk about general parlance and the idea that there's a significant effectual relationship. To me, in practice, we imply, as I said already, that if we remove the cause or some of the cause, the outcome that it causes will be reduced. Just as a reminder, correlation, association, and effect, and particularly to make sure you understand the distinction between association and effect. Correlation, of course, is just how X and Y look together. Is there a pattern where not the change in one leads to change in the other, but it looks like they are linked. Higher values of one running along with higher values of the other, lower values similarly running together. With association, that's correlation. With association, we say, what does this relationship look like? That association might be causal. It might be due to chance. And in fact, it might be due to some other problem in the data that we're looking at, such as the influence of another factor, confounding. And then for causation, implication that an increase in the value of X leads to an increase in the value of Y. So we're going to be focused here on effects and causal effects. So we'll turn now to the process of causal inference, and really causal inference in public health. I mean, certainly causal inference is a part of many scientific disciplines. Historically, if you go back in sort of modern medicine, the problem of how to infer causality arose as we began to identify microorganisms that were likely to be causes of disease. Robert Koch, who was so important in identifying some of these organisms, you can see anthrax, TB, the cholera and Vibrio, proposed a set of criteria along with his teacher, Henle, the so-called Henle-Koch postulates. And these had to do with the organism and the disease. And you can read these. They involve an element of experimentation, of culture, of causing disease with the organism in an animal. And these stood very well in the days of work to isolate microorganisms and then link them to specific diseases. The problem that came as we began to study the non-communicable diseases, particularly beginning in the 40s and 50s, was how do we interpret not experimental data and not data so specific as a particular microorganism in a particular disease, but the messier problem of multi-cause disease, like lung cancer or heart disease, where it became clear early on that there were multiple causal factors. And if you go back and read the literature of the 50s and into the 60s, there was a great deal of discussion of how to approach this problem, and particularly how to deal with observational data as opposed to experimental data. In the 64 Surgeon General's report, there's this brief chapter on these causal guidelines, and this is taken from that report, and you can see here are the 5 guidelines proposed in the 1964 report, and we'll come back to these in a moment. Now, in thinking about the process of causal inference, we begin, of course, by generating evidence, and if we're looking at people, this is the domain of epidemiological research. Clearly, for many of our contemporary problems, we're going well beyond epidemiological work, looking at toxicological research. For example, in the case of hazardous components of tobacco smoke, for example, we may well be relying much more on toxicology, understanding structure-activity relationships, than on actual human research. But the first step is the development of evidence, the domain of science. And then the next step is a process of synthesis, of understanding what evidence we have. Now, the norm is to do a transparent, systematic review. There may be, along with that, a meta-analysis, a quantitative summary of the evidence, and other evidence may be brought in. And so this is sort of a place of systematic review. And then, and I will comment that it's clear if you read the methods of the 64 Surgeon General's report, it comprised a systematic review. And then on to evaluation of the evidence, and this is where these causal criteria, guidelines, whatever we want to call them, play in. And this is very much has been and will remain for now the domain of expert judgment. There are alternatives and complementary approaches proposed, Bayesian analyses of various sorts that join different lines of evidence. Be careful here to not confuse the new causal modeling, which try and estimate effects that are considered to be under causal models of the underlying process, from the general process of causal inference. So here are the criteria proposed, offered by the Surgeon General's report in 64, and also those proposed in 65 by Sir Austin Bradford Hill in a well-known paper. And again, there's a great deal of overlap between these guidelines, and what they say is to evaluate the evidence using these guidelines or criteria in a holistic manner. Those reports would state clearly this is not a checklist exercise where one goes through and checks off how many of these criteria are met to make an inference. So I'm just going to run through these criteria quickly and sort of align them with tobacco. Temporality we already talked about. In the case of smoking a disease, clearly there's no issue here. People begin smoking at a young age, long before at least many of the chronic effects emerge. Strength of association, stronger effects are more likely to be causal. That's not because stronger effects are more likely to be true. It's just that alternative explanations, confounding and bias, become less likely as the strength of association goes up. A weak association, so-called, may be quite plausible, so the strength of association is simply a guide to the potential influence of bias. And if we look back at some of the early tobacco stories, here's lung cancer in males, the initial estimates of strength of association were really quite high, comparing smokers to never smokers. So strength of association was an easy one, for example, for active smoking and lung cancer. Dose response, again, dose response does not have to be linear on a biological basis, but if risk rises in some fashion with increasing dose or exposure, again, it helps us to set aside other factors and speaks to causality. And again, just another early example from the British doctor study of lung cancer mortality rates by number of cigarettes smoked, a clear dose-response relationship. Here is a plot. This shows 70 studies. It shows relative risk for lung cancer in men, current smokers versus never smokers by cigarettes per day. I put this together for the Minnesota tobacco litigation. Now, what you can see here is three important aspects of these guidelines. So one is the tremendous strength of association, relative risk of 20, 30, 40, so tremendously strong association. Dose response, and there's some noise here, but certainly the lines go up as the number of cigarettes per day goes up. And there's consistency. This is sort of a swarm of lines, admittedly, but you can see that they are quite consistent in showing things going up. So a useful example of meeting three of the criteria. Consistency is important because as we move from population to population or investigator to investigator, alternative associations like confounding, for example, become less likely if we see the same pattern. If there is some bias on the part of one investigator, but there's replication with others, again, it speaks to likely causality. So there is that picture. Now, here we have a meta-analysis done in the 1990s on passive smoking and lung cancer. And here there's results of about 24, 28 studies. There's a combined estimate at the bottom of about 1.25 for risk of lung cancer in never smoking women married to smokers compared to never smoking women married to non-smoking husbands. And you can see that the overall point estimate at the bottom is statistically significant. There's a lot of noise in the studies. Some have very wide confidence intervals because simply they're not large because we don't see that many cases of lung cancer in never smokers. So here, consistency is perhaps less apparent, but there's a great deal of imprecision. The relative risk is not 10, nor would we expect it to be. We would expect it to be substantially below that we see for never smokers. So again, this is one of those associations found to be causal, of course, by Surgeon General Koop in the 1986 report. And here's a very powerful conclusion from that report. Involuntary smoking is a cause of disease, including lung cancer in healthy non-smokers. Speaking of the power of a causal conclusion, of course, this conclusion and others and other reports were very much the impetus to move to smoke-free indoor environments. One other important piece of the plausibility story, removing the exposure should lower risk. And here's what happens, of course, when people stop smoking. That same set of exhibits prepared for the Minnesota trial. So you saw the 70 studies with risk going up. Now you see another set of studies where relative risk goes down as time since quitting lengthens. And then, of course, biological plausibility. Again, no firm guidelines here, but this is where we look at all of the evidence. And then considering whether there are alternative plausible explanations. One given a great deal of attention in the 64 Surgeon General's report and proposed by Ronald Fisher of Fisher's exact test, or the first statistical geneticist, was the so-called constitutional hypothesis that receives substantial consideration in the report. It may have some sort of new credibility given what we're learning about the genetics of lung cancer risk. Strength of evidence is an important issue. Remember at the start I said hazard identification, yes, no, and then I sort of backtracked and said, well, maybe we need to think about how much evidence there is and perhaps there are grades. So this is the language that we put into the 2004 Surgeon General's report in terms of classifying the strength of evidence. Sufficient, suggestive but not sufficient, inadequate, and suggestive of no causal relationship. So 4 levels of strength of evidence. So clearly sufficient, suggestive but not sufficient, and perhaps that conclusion would be for smoking or some other exposure sufficient to warrant precautionary action. But it would be an intelligible and understandable statement about the strength of evidence. One important issue and term often brought up in practice is the idea of equipoise, and those of you who do clinical trials may have heard this term. Where does the evidence balance hang in the sort of for and against causation? Are we above a point of equipoise, which would move us at least into that suggestive category, perhaps, or below it? Some years ago, I was involved in a report to the National Academy of Sciences on decision-making about compensation for veterans. And we put together a set of pictures sort of based on some Bayesian ideas about how to describe strength of evidence, credibility of causation. I'm going to show you 4 distributions of essentially strength of evidence, of belief. We're looking at some causal effect, and we're now looking at a distribution for values that that causal effect might take. So here is no effect, and here's increasing effect coming along here. So if you look at this, there's some possibility that there is no effect, but most of the mass of probability sits well towards having an effect. So that might be sufficient. Next, we have something where we've piled up a little bit more probability on no effect. We sort of shifted the distribution to the left, but we still have a long tail. This might be perhaps in the suggestive realm. And clearly, we would have most of the evidence above equipoise. Now, we're getting into a much more mixed picture. You can see we've got a lot of our probability piled up at no effect, and then some going on beyond it. And then finally, most of the mass of probability piled up at no effect. I think these pictures are useful for thinking about what we mean by levels of evidence and how likely we think a causal effect is. And it would be very nice to get to the point with sort of Bayesian approaches where we could bring together different lines of evidence and describe this in a useful way. So what we have now is experts who sit around and make a judgment. And for those of you who've sat around tables or written documents where you have to come to a conclusion, it's a challenge, for sure, especially knowing the implications of saying sufficient or suggestive but not sufficient. I think I won't spend a lot of time on this because I'm going to run out of time, but the idea of necessary and sufficient causes. So this became an issue dealing with smoking and the non-communicable diseases in general. So we moved from, say, TB, of course, where you can't have tuberculosis without infection with the tuberculosis-causing organism, the Mycobacterium tuberculosis. But you can certainly have lung cancer without smoking, and you can smoke and not get lung cancer. So this idea of necessary and sufficient is a useful one. Necessary, all cases of disease require the cause for the disease to occur. Sufficient, if all individuals exposed to the cause will acquire the disease. So you see the 4 possibilities when we cross-classify causes by necessary and sufficient. And it's sometimes troubling when people realize, for example, that smoking is not necessary to cause lung cancer. Never smokers get it because there are other causes. Nor does it seem to be sufficient by itself, since not everyone who smokes develops lung cancer. Now, it could be that if everybody who smoked lived long enough, perhaps to 100 years, eventually they would all develop lung cancer, but we don't have that natural history. So this is just an additional wrinkle, and I think one in terms of the regulatory decision-making is important to acknowledge that for many of the outcomes we're interested, there are multiple causes that we have to consider. So I'm going to skip these, and I'm just going to point out that a very important article and a very readable one on causation and these ideas of necessary and sufficient. It's Ken Rothman's paper in the American Journal of Epidemiology in 1976. So if you're not familiar with this, put it on your reading list to get a better idea about necessary and sufficiency. So we're skipping through some wonderful slides here. And just a few last concepts, and I'm going to take the last few minutes to talk about some causal frameworks. So thinking about causal chains and looking upstream to the causes of exposure, and this is just a very simple causal model where we have exposures in genes downstream driving disease risk, but upstream, of course, the causes of exposure, and this fits so well in thinking about tobacco-caused disease, because, of course, tobacco products are caused by the tobacco industry, and much of our policy work, including the Tobacco Control Act, of course, focuses now upstream towards the tobacco industry. So just the last, I want to go through a few examples. So one example of a causal scheme used in practice is that used by the International Agency for Research on Cancer in Lyon, France, an arm of WHO. And perhaps some of you on the call have participated in the so-called monograph meeting, where you spend about 9 or 10 days in beautiful Lyon, closeted in a room, doing nothing but working. And there are groups in these meetings that consider the evidence for cancer in humans and grade it, cancer in experimental animals and grade it, and look at the relevant mechanistic data. There's also a group that looks at exposure. This evidence is then brought together to do an overall evaluation of carcinogenicity, very much akin to our causal inference model, where the evidence is graded. Is there group 1 level of certainty the agent is carcinogenic to humans? Probably, possibly, not classifiable, and probably not carcinogenic. So you can see that the evidence is graded. Here is the actual way that this is done. Bringing together, you can see the table cross-classified by the evidence in experimental animals, the evidence in humans, and then the mechanistic data is used to perhaps change the category 1 would arrive at simply by using the human and experimental animal data. It was this kind of discussion in 2002 that underlay the conclusions of monograph of volume 83, which is on tobacco smoking. So here is IARC providing its conclusion, group 1, on involuntary smoking. There was actually a somewhat differently worded but inference that involuntary smoking must cause cancer in volume 38, published in 1986. Here is air pollution, again, where we looked at the epidemiological evidence, considered the animal evidence, and then also a great deal of experimental and laboratory assays on particles collected in various parts of the world. So here's an important conclusion with causal implications. So there is that group. And now just, I will say, volume 102 was on non-ionizing radiation, where the kinds of radiations came from cell phones. I actually chaired this meeting where we were confronted with very complicated epidemiological data, some experimental data, and some mechanistic data. And we used the IR approach, which led us to this conclusion of possibly carcinogenic. And this conclusion has actually proved challenging to explain in various settings where I've been called on to try and say, what does it mean for something to be possibly carcinogenic? My answer, it means clearly that the evidence indicates that we can't say it's safe, and on the other hand, that the evidence provides a warning. But we're clearly, in terms of these ideas of probability of certainty, not anywhere near sufficiency when we're at this level of weight of evidence. So these ways of expressing strength of evidence are important. So there's the overall evaluation there. Just want to go on to one different process. In the U.S., the Environmental Protection Agency has something called the IRIS, or Integrated Risk Information System program. IRIS is a long-standing program of the EPA. It does two parts of the risk assessment. It makes a judgment as to whether a hazard is present, and it gives a best estimate of dose or exposure response for utilization in risk assessment. And you're probably familiar with some of the reviews that have been done. Formaldehyde as an example of one controversial one, dioxin, another, arsenic, another. These are important because they often underlie major regulatory decisions that will may cut across the interests of major stakeholders, like formaldehyde. Some years ago, I chaired a review of EPA's IRIS assessment for formaldehyde for the National Academy of Sciences. We looked at the question of whether EPA had met its own guidelines in reaching conclusions. Set that aside, but what we said at the end of this was that we thought there were problems in the IRIS process and talked about the need to revise those processes, bringing in some of the just practical processes that I showed you before, like doing state-of-the-art transparent systematic reviews and a clear-cut, open weight of evidence analysis. So the end result, and I apologize for the quality of the slide here, was the evolution of a new process for doing these IRIS reviews. And I subsequently chaired a committee to look at this evaluation. And what it does is it begins with sort of a scoping or framing of what is the underlying question. And it's important and critical in launching on a causal inference process, judging how much evidence there is, to be very clear up front as to what are the questions to be answered. And in many of our causal questions in practice, then that becomes a set of systematic reviews, not just of the epidemiological evidence, often there is none, but also the toxicological and mechanistic evidence. So we end up doing perhaps a set of systematic reviews that then feed into an expert judgment process and ultimately decision-making. So these kinds of diagrams of what we're doing and what we're after are very, very useful. I'm just going to end with sort of my most recent foray into looking at processes to move from evidence to decisions. So much of our testing of chemicals is going to move from using whole animal bioassays, often done with rodents, for example. Such assays are expensive. They utilize live animals, which of course has fallen out of favor. We're substituting high throughput testing in various cellular systems that are done robotically that generate massive amounts of data. And with that comes the burden and challenge of actually weighing and evaluating that evidence. So in a report literally just released 2 weeks ago by the National Academies, we looked at this, and here we have some new causal inference challenges related to how to deal with this new information. To say, how do we know that a pathway that leads to disease has been perturbed? How do we know that a pathway leads to disease? And I will just say these are important concepts that underlie also ideas about what is being called precision medicine. So the causal inference challenges are going on. These high throughput approaches are likely to become very important in testing particular chemicals that may be in, say, electronic cigarettes, perhaps flavorings, or perhaps compounds in tobacco smoke. So our challenges will continue. So I think I've made it all the way to the end. I think we had one reference that we provided for today's session. This is a review article in the American Reviews of Public Health with Tom Glass, Steve Goodman, Miguel Hernan, and myself as authors, and I think it's a readable introduction to what is obviously a very vast field. So I'll stop, and we have about 10 minutes left, and I hope you have a lot of questions. Thanks.
Thank you for that wonderful presentation. Now everyone should be back to the main screen, and you should be able to see the chat box in the lower right. So please start to chat in your questions. Alicia is writing there now. So please chat there, and as we wait for the questions to start coming in, I'd like to just make a plug for the next session in the series. That'll be on February 8th from 1 to 2. The presentation is titled Directed Acyclic Graphs, Understanding this Approach to Interpreting Data. Registration is open, and please look for additional announcements to register. We hope you will join us again for the third installment in the method series. As for slides and the presentations that we've had today, the presentation is being recorded and slides will be available. Please look out for the next sector digest, which will contain a link and instructions to access those for future reference. We'll take a moment to see if any additional questions come through.
Can I make a comment while we're waiting on the presentation? So I think it's nice to see these more general presentations followed by a discussion of DAGs, which are a very useful way to make sure you have thought through what underlying causal processes are. And then I mentioned this, the last presentation on estimating causal effects will sort of refer to this emerging area of causal modeling with assumptions based around ideas perhaps embedded in the DAGs of what the relationships are, and then models that appropriately represent those relationships.
All right, it looks like we have our first question. Dr. Ioannidis presented last week noting the Bradford-Hill criteria do not always seem to work. Can you please comment whether the criteria need to be revisited?
Yeah, so first off, we should substitute the word guidelines because that is what they are. I think what you have to think through is how these guidelines are used in practice. So they're applied by people. They're done by different groups of experts. And in fact, expert groups don't always agree. And so whether that is, quote, not working or a reflection of the strength of evidence and how different groups respond when, in fact, there is uncertainty. I'll give you a couple of examples. Formaldehyde is actually a very good one, where different groups of expert panels convened by agencies have reached different conclusions. If you go look at the core evidence, it's not in sort of, to use a sports analogy, the slam dunk category of smoking and lung cancer. There are often far messier situations, and there's a little bit of empirical work, but not enough on the fact that expert panels may respond to the same evidence in different ways. Just one more elaboration on this. In the last report I discussed, the one on pathways, we actually suggested that work be done because in this complicated arena of looking at pathways, we're in fact still going to be relying for the moment on expert judgment, that we look collectively at what the experience is and captured. But second, that some empirical research be done just on this. I'm not sure I actually see that the criteria need to be revisited. I think they certainly need, in the cases of some of our new lines of data, reformulated. Those of you who are really interested, I think this has gone the furthest in cancer, in part because IARC has that territory as one it looks at. They've recently published a paper, Martin Smith is the first author, called The 10 Hallmarks of Cancer, talking about how to look at the mechanistic evidence and see what is known that is useful to inferring, in fact, that the mechanistic evidence points to causation. So I think certainly Dr. Yanid is correct that we, in dealing with challenging evidence, are often challenged to reach certain conclusions or conclusions that appropriately acknowledge uncertainty.
Thank you. We have time for probably one more question if there are any more questions coming through. We know it's a lot to take in a short amount of time, and if you have any additional questions, feel free to submit, and those can be addressed offline at a later time. With that said, it doesn't look like there are any more questions coming in, so feel free to submit to Sector, and we will have your questions answered at a later time if you have any. So thank you again to our presenter and to everyone joining us today. We do ask that there is a poll at the end. If you could please answer those few questions, that would be great to get your feedback on how we could continue to improve the webinar series and better address your interests and needs. So thank you again, and we hope you'll join us next time on February 8th. Thank you.
Great. Thank you.
Thanks.